estrogen. I feel like there's a big misconception with estrogen. When people think of estrogen, they think of cancer. So I just wanted to know your thoughts.
Honestly, that's a huge issue I come into contact with when discussing hormones with patients. And that's really based on the WHI. It was a big study that really changed the way we thought about hormone therapy. The WHI initially came out, and many of the participants had stroke the first year, and then there was this arm with an increased risk of breast cancer. The data from that study was re-looked at and published in the Journal of Infertility and Sterility, where they actually showed that the estrogen or Premarin, and it really wasn't estradiol, it was Premarin, which is a horse-based estrogen, and only 10% estradiol. So that's the estrogen that our bodies respond to. But that arm really did not show an increased risk of breast cancer. The arm that showed the increased risk of breast cancer was the estrogen or the Premarin and the synthetic progestin arm. And we know that synthetic progestin is teratogenic. You can't give it to a pregnant woman. Micronized progesterone, which is a natural progesterone that our bodies recognize as our own, is not. It's very protective. So looking at the data, the estrogen arm did not increase risks of breast cancer. And it's really unfortunate, because estrogen is so important.
Well, what do you mean estrogen's important?
So estrogen is very protective. There was actually a study that started back in 1976, and it's the Nurses' Health Study. So it actually took nurses and watched their predictable response over time. There was 121,700 women. And estrogen showed an all-cause mortality protection of 30%, which is unbelievable. So if a female and a male has good estrogen, and we're looking at females now, so menopause, the moment you go in menopause, if you start estrogen therapy and you continue it for 10 years, your risk of vascular dementia decreases by 85%, 50% decrease in cardiovascular disease. That's amazing. So even the WHI, when they use Premarin, which is a horse-based estrogen, so much more risk of blood clot. Initially, the risk was increased, but after 1 year, even those patients had a cardiovascular benefit and protection of 50%. So that's incredible.
Yes.
Osteoporosis, 35% improvement of that. Balance, so just not falling and breaking your hip, 11%. And then urogenital sepsis or UTIs, a protection of 60%, which is incredible.
Yes.
If you're off estrogen therapy, just 2 months off estrogen therapy, your vaginal flora changes. Your risks of bladder infection increases, and as we age, that leads to mental status changes, falling and hurting yourself. So estrogen really is life-saving. It protects our lipid panel. I can go on and on, and so I don't want to break down into all of that. But my thing is go out and look at the studies. Yes. Do your own research. There's a huge difference between synthetic, and there's a huge difference between bioidentical. And why would we take an estrogen that is in a horse? Like, it makes no sense why we would take something that wasn't natural.
So Dr. Botha, when you're talking about synthetic versus bioidentical, let's kind of like break that down. I think that people just hear it and maybe it goes over their head a little bit, but let's break it down and help people understand.
So big issue with a lot of the early studies are that there isn't a difference between that. And honestly, I didn't know what a bioidentical hormone was. So I didn't either. So I didn't recognize the issues with the studies. But synthetic is a hormone that doesn't look like our natural hormones. So it's a metabolite not recognized. So it hits the receptors but doesn't unlock them. And that's a huge difference. It's more estrogenicity, so higher risks of stroke and blood clot, right? It also really doesn't help with a lot of the symptoms. So a lot of patients would come in, we'd place them on it, and they were still symptomatic. Whereas bioidentical is non-patented because it's the same chemical structure as our own body. It is made in the compounding industry. So it's not something really that the pharmaceutical industries can partake in. You can get estrase, which is probably one of the better ones, but you're not going to have the same levels as that at a compounding pharmacy because they're able to do what's called micronized. And so we're able to get levels that are really protective. And that's what's important, is to establish the levels that we had in our youth. And there are definitely levels that we need to reach in estrogen for all this protection. And estrogen actually improves our lipid panels. If you look at women who are menopausal, they have decreased HDLs and increased LDLs and increased triglycerides. Also increased insulin resistance, and that's the buzzword, right? We're now realizing with these GLP agonists that we can improve overall inflammation by decreasing insulin resistance. So menopause, which is no estrogen, is a setup for inflammation.
So let's talk about estrogen excess. Let's navigate that. Let's dive into that.
Okay, that's honestly, I think, what brings most patients in to see me. By definition, honestly, that's perimenopause, right? So what is perimenopause? I feel like everybody knows that it's the start before menopause, but what is this? So perimenopause is that great space where anything and everything that happens to you is normal. It's just, I think, a area for us to say, you're fine, right? But what happens is in perimenopause is you have an imbalance of your hormones. So it's the start of the decrease in androgens and the period where your body doesn't release the follicle or the egg anymore. So you have a follicle there, or a cyst, and it produces estrogen. And what's supposed to happen is mid-cycle, it's supposed to be released, and what's left behind is a different cyst that makes progesterone. And so there's got to be a balance there. I always say estrogen's a fertilizer and progesterone's a lawnmower. And if you don't have both, then you really are symptomatic. And so estrogen excess, by definition, is higher than 150 on your labs, which month to month can be different. So what happens with that cyst is it stays there and it takes 4 to 6 weeks to be resolved. And that entire time, the body is just making estrogen. Estrogen stimulates any receptors that are positive for estrogen, so uterus and breast. And so high estrogen actually will make you feel very anxious, very overwhelmed. It causes bloating, it causes breast tenderness, and watery discharge. The other telltale sign is if you jump up really fast and you fall over because your ovary is suspended by a ligament. So if you have a big ovarian cyst in there producing a ton of estrogen, you're going to get up and feel like you just twisted your ovary, right? It's very similar to the ligament pain of pregnancy. So that's really what brings women into me, because 1 month they feel very overwhelmed and then the next month they feel fine. So my job is to educate them so that they can improve month to month how they feel. So low estrogen is not good either. That makes women feel very overwhelmed, but high estrogen is almost worse.
Yes.
And so in both men and women. So really navigating perimenopause, I think, is way harder than menopause. That's a struggle for a lot of women. And I have women all the time, their providers say they're normal and they're fine. And they find me because they know they're not, and there has to be something out there. They're not feeling like their self. And the big issue is perimenopause is also the period where testosterone's low, and for most women, DHEA is low. So progesterone actually is something that is protective, and so is testosterone. Both of those, they stimulate a gene that causes cell death to cells that are not doing the right thing. So if you have your protection low, and then on top of it you have insulin resistance there, women have more truncal obesity and male pattern balding. And so brain fog's real. And you do not want to give these patients estrogen because it's going to make it worse. So what they need is progesterone. So you can have night sweats and you can have all the same symptoms of menopause and perimenopause, but it's not because of estrogen deficiency. So that's really frustrating for somebody who's had a hysterectomy because they get put on estrogen. So we need to check blood work. Blood work is very important. And if you're not having blood work done, then it's really difficult to determine what's going on because they're women in their 30s going into menopause. right? So perimenopause is 15 years prior to menopause, generally speaking. So it can start in early 30s and it can start in late 40s. So we're all very different. Genetics is a huge part of it, but a lot of us are very inflamed now and have a lot of endocrine disruptors. So that also will affect ovulatory patterns in women. And that's what excess estrogen is.
So if perimenopause is excess, is menopause deficiency?
Yeah, absolutely. So by definition, menopause is not having your period for a year. The issue that I have with this is many women they can have what's called oligomenorrhea, which is no periods and still have estrogen. I actually had several patients who came in after 2 years of not having their period. They had high estrogen, so they had truncal obesity, so they were a little overweight, and came in hemorrhaging. And that's an increased risk there for them, right? So I like to either do a progesterone withdrawal or check labs. Because like I said, we talked about perimenopause. You can have night sweats and hot flashes. So menopause and perimenopause have similarities, and you don't want to rely on feeling like you have night sweats because that can be a thyroid dysfunction as well. So we have to look at everything. Menopause is usually associated with vaginal dryness and pH changes. So the tissue gets thinner and more irritated. And so our vaginal pH, I know as a GYN, when patients would come in and they've been on antibiotics, that destroys the natural balance. And our balance in our vagina is important. And that's normalized with estrogen. It helps our pH, right? So not only is estrogen, we talked about the protection that it has, it helps decrease risks of heart disease, but it does help protect our vagina. So it prevents atrophy. I had a patient come in wanting rejuvenation, and I asked her when her symptoms of incontinence started. And it started when her period stopped. So with menopause. So you can have incontinence because the tissue thins out. And all we do is restore the balance and replace estrogen, and incontinence can improve. So it is definitely preventable. A lot of incontinence that we have is preventable, but the protection of heart disease and the global importance of estrogen is what matters.
Yes. So what would you say the take home about estrogen would be?
Don't be scared of estrogen therapy. It's very protective. Users of hormone replacement have better cognitive testing. Their risk of dementia is reduced. Their risk of heart disease is reduced. So atherosclerosis, which is because of their lipid changes, so increased in cells that line the vessels, that decreases. The pH of a vagina and getting UTIs decreases. Vaginal atrophy and painful sex, incontinence, osteoporosis. I mean, that in itself, you lose bone density rapidly when you hit menopause. And so all of these things benefit us. Users of hormone therapy have better quality of life and they have better health. And so I strongly encourage you to look at the data and find a physician who understands hormone therapy and can do a full approach. It's not cookie cutter. We have to look at levels. Excess makes you symptomatic, and deficiency is also of health concern. So we have to do correct replacement. Dr. Tracey Botha from Moy Med Spa.
Cian from Moy Med Spa.
And we're here to educate you more on hormone therapy. This is my passion, and I always just joke and say it's my going to heaven medicine. So hormones have changed my life and many of the patients. I've been doing this for over 15 years, and my job is to educate my patients and to educate my colleagues. I'm now teaching other medical professionals about this incredible medicine, because the more doctors out there that are able to treat all of you, the better. If you want to hear more, like and subscribe, and we will be posting more content to educate you more. Dr. Tracey Botha from Moy Med Spa, where I want to educate everybody on hormone therapy so you can be your own advocates. Stay tuned.